Another study showing that epinephrine doesn't do what we think that it does. If it's Monday, it's magic. Hey everybody, welcome back to the Monday Afternoon Journal Club. Ed Bowder and Dan Schwester here, and today we're going to talk more about epinephrine. 2024 seems to be the year of epinephrine studies, Danny.
Yeah, a lot of cardiac arrest studies, a lot of stuff on epinephrine coming out. Most of them are saying kind of the same thing, Ed.
Yeah, it turns out things that we've been doing for 70 years don't necessarily work just because we want them to. So we actually have two studies to share with you here. One is they're pretty much studies based upon studies. So here we have a journal club this is from Annals of Emergency Medicine. So this is from August of 24. This is their journal club talking about a retrospective multi-agency target trial emulation for the comparison of post-resuscitation epinephrine to norepinephrine, which is a very wordy title.
Thanks, Remley.
Thanks, Rem. So this is from Tanner Smida, Remley Crow et al. The actual review was done by Dr. Awadani and Dr. Hines. So this is the review that they did in Annals, and I'm just going to go through this real quick before we get into the actual paper. So in this study, there was 1,893 patients that were included. Rearrest happened in 383 patients, and we're going to go into these numbers eventually. But essentially what they were looking at was after an arrest, they wanted to see if giving epinephrine or norepinephrine showed any sort of superiority in maintaining this patient's perfusion. Now, this journal club that Annals did is based upon this actual study, and this actual study came out in May of this year. So this is coming out of Resuscitation. And essentially what they looked at here, we're just going to go through this abstract and then we'll talk about the actual paper. So we had 1,893 patients treated by 309 EMS agencies. They had a little over 1,000 patients get epinephrine and a little close to 900 get norepinephrine. This conclusion was in this multi-agency trial, the use of post-resuscitant epinephrine infusion was not associated with increased odds of rearrest in comparison to the use of an epinephrine infusion. So what they were talking about here was after ROSC, do epinephrine or norepinephrine maintain their actual rhythm better? And essentially, this is a non-inferiority study, but it showed that epinephrine and norepinephrine work or don't work essentially about the same after post-arrest. So looking here, average of 8 minutes to rearrest when given epinephrine, 7 minutes for receiving norepinephrine. And then again, here we see in this chart here, the rearrest, no rearrest, and all of those. But essentially, again, we're looking here where we see that there's time to rearrest in both the epinephrine and norepinephrine groups. And also, we know that the data supports that epinephrine does not support improved 30-day mortality. So there's kind of a lot to talk about here with these two data points and these two studies, but we've talked about epinephrine before previously, Danny. Right now, the way that the data is running in the past 5-10 years, it doesn't seem that epinephrine improves outcomes. There's agencies that don't even give epinephrine in cardiac arrest anymore that oddly enough are showing an improved ROSC, which is something that is not taught in our classrooms. But now we have this evidence that shows that epinephrine doesn't really work in cardiac arrest to improve outcomes when they get into the hospital. If they rearrest, we now have data that shows that our pressors, whether they're epinephrine or norepinephrine, don't really work. One doesn't work better than the other. So I guess the question we have to start asking ourselves is, what are we doing for cardiac arrest patients?
Well, it's kind of complicated here, and it's kind of like I think we have to have a serious talk about epinephrine. And I think we have to have a serious talk as a community and as a profession about cardiac arrest. The numbers here are pretty good. The sample size was fairly good. These are agencies that are doing pretty much everything they can for their people. We're not doubting that. But again, as a lot of the studies have shown, it's not working. It's not translating out. And we've had 50 years of ACLS and chemicals and epinephrine and all this stuff about cardiac arrest. And we come back to the same conclusion, right? And it's almost like we're banging our head against the wall. Except for a very small subset of patients that are presenting with a very, very delineated set of symptoms or signs, cardiac arrest survival has not improved above 10% for the last 40 to 50 years. Even with all the advances we have, all the stuff we have in the back of the truck, all the stuff we have in the ED, we're still not getting above 10%. And that's not even counting, that quality of survival where, a significant percentage, excuse me, in this study were discharged to a long-term care facility or discharged to a skilled nursing facility. And again, we start talking about quality of life and what are we actually doing? I'm going to come out and I'm going to be kind of provocative here. I think we've been conditioned for so long that cardiac arrest is the highest level of emergency we can attend, and that it deserves 110% effort on every patient, no matter what the presentation, no matter what the standings are, that we do this all the time. And we throw epinephrine at people and we subject them to mechanical CPR and intubation and positive pressure ventilation and even other things down the road. And we're still not getting above 10% survival. I think it's time with 2025 coming around, and we've got you'll have new AHA guidelines coming out soon. ILCOR will be putting out recommendations soon. I'm really interested to see if we're really going to stop the madness. Are we going to just recognize that for a majority of people, when your heart stops, that's the end of it? Most cardiac arrests that we see in the field are pre-terminal conditions. That person who dropped mowing their lawn in a VFib VTAC arrest, that's not what I'm talking about here. That's a completely different person, and that's a potential clean save. That's right. Something we need to do. But people with multiple comorbidities, people over age limits, people who are who present unwitnessed, we work all these people. And I wonder if that's the right thing to be doing now. All this data, all these studies are pointing me to one thing. It's not working. We're not helping people. And we're not helping ourselves, because I think there's a psychological moral injury here when we're forcing clinicians to try to do these. It's almost like a Sisyphean battle, right? Like we're trying to push this rock up the hill, but we're not going to get anywhere because the rock's going to be down at the bottom of the hill tomorrow. Do we need to have a serious discussion as a profession? And I think the answer is yes.
And not to mix our metaphors, but it's either Sisyphus or Prometheus, right? With the eagle coming down and eating him every day.
Every day.
Every day. But so in this type of setting, I think what we're seeing writ large, and again, the theory for epinephrine is the way that the drug actually works. In theory, we would see, improved contractility, improved oxygenation. And this is all stuff that it tends to work in vitro in the lab, right? If I take a piece of muscle and I apply epinephrine to it, or adrenaline, however you want to refer to it, that muscle is going to show improved squeeze, right? And improve actual activity.
Sure. And it makes a lot of sense, right?
Yeah. And so the way that the drug works is how the drug should work in actual in vivo in the patient. The problem is that it doesn't. And this is what we've learned from, studies for a decade now, at least 15 years. And we're learning that the variable of using epinephrine doesn't actually improve outcomes. So, and the way that the drug actually works, right? Epinephrine has both the alpha and beta effects that you want to have. So if the problem is that the heart isn't beating, then it would stand to reason that giving a drug that would cause the heart to beat would work. The problem is, and especially in post-arrest, you've got this damaged myocardium. We don't know what type of damage there is to it. 5 to 7 years ago, we finally decided as an industry that people who have arrested and have gotten a ROSC should go up to the cath lab and be treated like an MI, because there's something that predisposed them to that actual cardiac arrest, right? And I think that it's like, okay, well, we see a cardiac arrest. We know that we have to do this. We have to give them epinephrine because the problem is there isn't enough circulating epinephrine. And it all kind of makes sense on paper, but I don't know that that's actually, it doesn't pan out in reality. And then giving these drugs post-arrest. Now, this is just looking at epinephrine and norepinephrine. Certainly there's other pressors that can be used, and I'm sure there's other shops and hospitals that use different pressors. We're just looking at this particular study as it pertains to pressors like epinephrine. And it just doesn't change or improve outcomes. And there's plenty of data now that's extant to read through that and to understand it. But I almost wonder, this feels like almost like a sunk cost fallacy, right? Where we're putting all of this medication into people because it's what we've always done since the 60s, right? And now, we're this far out from it, and we're still doing this because it's just what we've always done. And there's interesting observations from people in the FOAMed community and, in medicine writ large, where the conversation is, ACLS is for dentists. ACLS is for, office workers who don't see these patients all the time. And I think admitting that is kind of one of the strong things that we see in the industry, because if we're just saying, like, listen, ACLS is not a bad, jumping off point. It's not a bad start point. And if we have to educate medics or EMTs even who are going out into the field, we're going to have to give them something to work off of, right? So I think ACLS and everything that the AHA puts out is good for an intro. Right. But once you actually start getting an understanding of the physiology behind these medications and how human physiology works, you start to notice that even though all of these things should work in theory, they're not working in practice. So at what point do we escape this sunk cost fallacy and start having an actual conversation about what works in resuscitation? It feels, and this is where I get frustrated, because for a decade, we've been talking about how early CPR, early defibrillation is what saves lives in cardiac arrest. You and I have been to several conferences where all the cardiac arrest data is, this is what works all the time, right? There's speakers nationally and internationally who have gone through all of this and have talked about, like, this doesn't work. This is what our shop is doing. We know in Florida, they're not using epinephrine the way ACLS recommends. We know in King County, Washington, they've just done away with asystole. Like, we're only using survivable rhythms. So there are programs that are working toward, actually forwarding medicine. And I wonder if, I guess I worry that we've gotten this impression in medicine, in EMS, that if we don't do something, then, there's going to be a lawsuit, or if I don't do something, I'm going to get my chart QA'd, or I'm going to hear all this stuff. And what worries me is that there's a point in time where we cross over from doing what is going to be right for the patient, doing what's going to improve outcomes, and doing instead what makes us feel good, knowing that, well, if I don't give epinephrine to this cardiac arrest, my medical director is going to QA my chart, as opposed to, if I don't give this patient epinephrine, I might actually be improving their survival.
Or the fact that if we don't do something, we're nothing. That we have this idea that if we're not doing something, and we're in this high stress, high speed type organization where we're expected to be responders, to get on scene, to do stuff, to bring order to chaos, there's a lot of psychological nudges, so to speak, towards, we got to do something. We got to give it the college try. We got to give them epi. Why? We didn't know, it probably doesn't work, but we're going to give it a shot anyway. Because if we're not doing something, then we're nothing. And I don't think that's where we need to be as a profession at this point. I think we need to just take a serious look. And ACLS is fine. It's a great framework for everybody to function on as a baseline. It's not the be all and end all, and it does not really speak to the skills of a clinician, or it doesn't make you a resuscitationist. It does not. No more than taking PHTLS or ATLS makes you a trauma surgeon. It's not going to happen in a weekend. What it does is give you an idea of how to work in that framework so that people can come in and use their expertise. But we need to seriously talk about what's working in resuscitation, what's not working, when should we apply a treatment, and when should we allow a natural death.
No, I think that's right. And another thing in this study is they talked about how they classified out of hospital cardiac arrest. This paper is very well written. They went through all the different variables, and they take the time just to make it very clear what they're talking about. They are very specifically talking about, post-arrest with a ROSC. But when they talk about out-of-hospital cardiac arrest, they talk about, presumed cardiac respiratory asphyxia, drug overdose, or other. And so again, it's important to mention this study. They're talking about medical cases, not trauma cases, because we already know that, CPR and epi and trauma doesn't actually work either. But looking at this study, one of the groups that they were talking about essentially were those that we would probably consider probably moribund in the first place, right? We know that if someone is, let's say, 85 years old and they go into cardiac arrest, it's probably due to the multiple sequelae that they have from their previous injuries or their previous illnesses. So one thing that I want to just talk about real quick is there is a reality that we have to focus on and remember that life is a terminal condition. So when we have these settings, and just to dovetail off of your moral injury point, how many arrests are we sending our providers to knowing that the effort is going to be futile, knowing that you're going to go in, you're going to break this, elderly patient, you're going to flail their sternum. And we're doing that just so that we feel like we did something. So I want you to talk about that a little bit too, Dan, just that moral injury aspect of it, because there's, again, plenty of data, plenty of research showing that, depression and suicide among EMS workers is disproportionately high. And might this be something that's a corresponding factor to that, where now with all this extant data, we know going into a cardiac arrest that I'm going to go in, I'm going to do CPR on a patient who's been down for 45 minutes. I'm going to give them epinephrine. I'm going to have an asystolic rhythm and not going to be able to shock them. So I'm going to go in there. I'm going to do the old, we talked about the college try for 20 minutes and then get out of here. I don't know that that's the most effective way for staff and for EMS workers to maintain their sanity.
I don't think so. I tend to agree with you. And I have an interesting anecdote for this. We're coming up again on the anniversary of 9/11, and one of the resources that was used at the scene of the World Trade Center after the bombing or after the attack was they used search and rescue dogs. And they were using them in the beginning in a rescue/recovery type phase to kind of save people that were trapped in the wreckage. And they started to notice something with the dogs. The dogs kept finding, not finding live bodies or not finding people that were alive, started to affect the mental health of the dogs. The dogs became listless. They didn't want to do it. They were kind of half-hearted. There were issues. They would actually take a person and put them into the pile at some point just for the dogs to think that they found somebody. And that speaks to me on these when we talk about this, because if we're going to do that for search and rescue dogs, what are we doing for the paramedics and EMTs who go to cardiac arrests on a daily basis, knowing it's a futile effort, knowing that because of protocol or because their medical director doesn't have a level of trust in them, or there's situations at the scene that are emotionally charged, that we just have to do this and we know it's not going to work. And you've been on that type of call. I've been on that type of call. I think anybody in EMS who's been around more than a week and a half probably has gone on that kind of call. I don't know that anybody's studied this, but I would say it's probably contributory. If everything is a negative outcome, you tend to have a negative outlook. And I think this may actually hurt people that we could save, because if we regard every cardiac arrest as futile, then we aren't ready for the clean save mentally. We go through the motions, we do the protocol because we have to, and we're not thinking, and we're not doing what we have to do. And subconsciously, can that have an effect on patient care? I'd like to say no, but at the same time, if it works, if it works for a Labrador Retriever, I don't know how it wouldn't work for a human.
No, and I think that's right. And my anecdote from that was my grandmother was on the pile actually working with the dogs, and that was essentially her feedback at the time too, was that there's kind of sort of a sense of defeat. And I think all that's right. And again, trying to convince staff to go into a resuscitation that we know is going to be futile. I mean, getting those calls at 2 o'clock in the morning that is going to be a cancel is frustrating enough, let alone, going into an arrest that you're not going to have a positive outcome. But we want to know what you guys think. We want to know if you've read this paper. We're lucky enough to know a couple of the authors, and these guys are great. This paper is very, very well written. But we want to know what your thoughts are about epinephrine in general and giving epinephrine post-ROSC. Is that what your shop is doing? And have you seen any different outcomes? Because the whole point of doing this is to improve outcomes for everybody. But if you've read it, if you like it, be sure you subscribe with that arrow, a little button that's going to come up on the screen. Check out all the rest of the stuff we have on YouTube, and check out the Overrun podcast wherever you get your podcasts. And for the Monday Afternoon Journal Club, Ed Bowder and Dan Schwester. Oh, also check us out on EMS One too, because we have a whole bunch of stories on there too. Oh yeah, we're all over the internet because the sun never sets on the Overrun empire. Have a good Monday afternoon, everybody. We'll talk to you next week.